Well, ladies and gentlemen, thank you very much for attending this lecture on nasal CPAP and you. So, my name is Jim. I'm from respiratory care. I'm one of the clinical specialists downstairs. I usually oversee transport, but at this point in time, I am overseeing 9th floor, which is great too. Like to teach. Adam here will tell you that I'm kind of good at it. He usually does most of the work though. All right. So, when we're talking about CPAP, the general idea we know is to increase functional residual capacity, make sure that we have a good PEEP level so we're setting the airways open, better diffusion across the alveolar capillary membrane. This is great. This is what we want to do. So the problem is where does it differ from high flow? Because most of you are used to high flow, correct? Mm-hmm. So the difference is this. When it comes to high flow, you have air entrainment. The cannula does not occlude the nose completely, correct? Mm-hmm. So when you do occlude the nose completely, that flow, as it goes into the patient, overcomes resistance, creates a pressure. That's your PEEP. Okay, positive end expiratory pressure keeps the lungs from collapsing. A higher amount is required to help the patient breathe, eliminate work of breathing, cause them to become less tachypnic, hopefully increase saturations. Again, better gas exchange. That is our overall goal here. We want to decrease airway resistance. So far, you with me? Mm-hmm. So when it comes to, we'll say, high flow on a 9-kilo child, we figure we'll just make math easy here. 2 liters per kilogram, you know your max flow is 18, correct? You get to use smaller flows at this point. You don't really need 18 of flow. You do that, you're going to have a PEEP like 15. They really don't need that high. So generally speaking, you'll see more to about 8 to 10 liters, which is good. But again, your nares are sealed off, which is what we're supposed to be doing. Now, I'll pass this around the room here. You have your prongs. Okay. Nice little sizing guide. Oh, wait, where does this all come from? Every one of these kits, this whole setup here comes with one of these because we need to be able to put it on the patient's face, right? So, what's in this kit? You have a size guide, which essentially figure out what size your nose is. This is for prongs. This is for mask. Okay. It's going to have one of these. Don't lose them. And I'll show you why here in a minute. And it also comes with this generator kit and a set of small, medium, and large prongs. Okay. Does that mean that you have to use prongs? No, it doesn't. Because we also have masks available. If you want to go ahead and pass it around. Now that's an extra small. But we also have small, medium, large, extra large, just like the size guide will tell you. All you have to do is ask your therapist. Most important measurement that you have to have with your patient is head circumference. There's a reason for that. So we'll pick our headgear. If you'll notice in the top corner here, it gives you what size each of these should be. Okay, so our top size on this is 42 cm. So if you've got a little melon that's more than 42 centimeters, we can't do nasal CPAP. We've got to consider other options. Okay? That's why we have that. Now, what this headgear translates to is this here. You'll notice if in case that you're not 100% sure what their head circumference is on, while they're on CPAP and they need a new headgear, you can't go to Epic right away and look. Just look on the back of this. It gives you the size and the centimeters. Okay. So how do we get little one on this? First of all, they're chugging away. We need to get good stemming of the airways open and eliminate work of breathing, right? So the first thing you're going to do is
call you.
Call the physician.
Well, I figured that.
You got to talk to the docs. Okay. First and foremost, and if I'm out of line here to say this, Joe, notification of an attending. Okay. That is tantamount. It does not matter what time of the day it is. You need to contact an attending. Okay. At that point, I'm sure, as you have said before, you're contacting us. Now, the good news is now we don't have a therapist that is running to 7 West, 6 North, 6 Central, 6 West, or, well, I usually work adults. I just got this assignment here. So, no, we are all children's trained, which is good news. So, call your therapist. And if that therapist needs help, they'll call another therapist. But this is important. Okay. So kids chugging away. You've called the attending. You've called the therapist. The attending and the therapist have agreed we need to put this baby on CPAP. So we've got our head circumference. RT has got the machine. This looks great. Okay. Looks like it's a medium. Kid's 33 centimeters. We take this spider looking thing. Okay, now we're not doing this alone. I need a nurse at bedside because this is always easier when I got two sets of hands, including my own. Okay, so there's easiest way to do things is swallow the baby because they will try to help, and it's no help to us. Okay, so however we lift the child, set their head right where that basket is, and of course down across the nape of the neck there. Okay. Now what's really cool about these, but they're numbered on the edge here, what goes first. So you have number 1 on the edge here. So you put that across, you have to hold it in place. See what I mean by if the baby's helping you and I'm trying to do this by myself, it's not very fun. Okay. This has the number 2 on it. It comes down like so. This has a number 3 right here. Tighten that all up. Pull it across like that. Now what do I do with this? Back like that. Now why this piece is important is because you put it across here. And this is eventually what's going to hold your manifold here. I'll show you here in a minute. Now we go to the machine. You can still be doing this while they're on high flow. Making sure that you have 2 sets of eyes. Turn everything on, goes through its self-test. Woohoo! That there, not to worry about. It's its own self-test. So what I have to do is I have to pick a set of prongs or a mask. In this case, I'm going to pick a mask. It's hard to get the prongs in the baby at this point. So this can only go on one way. There's an indentation here because it works with the tubing. Indentations here, and tubing there. So we go ahead and place our mask on. Say I want a CPAP of 5. I just turn up my flow.
There's so many Mickey
Yeah, here this is sleep.
Yeah.
Here, and
That
mine all
sounds
the time
like
is when my
the
boss
patch
yells at me. So what you have to do is occlude it, so that way it gets that pressure. We pick whatever oxygen that we want to be on. Go through, just let's see, it's giving us 4.4 a peak. Okay. Anytime it's occluded, the machine's saying this is what I'm feeling. I'm feeling this set. If I have to go up the flow, say I need more, about 6 or 7. All I got to do is go up on the flow. Increase flow, increase peak. Okay. It's directly proportional.
Nobody should be touching flow with a respiratory therapist. That's not the same as.
It's not the same as high flow.
The PEEP is the number that we're worried about, right? So like when you talk to me or the residents or whatever, like PEEP of 5, PEEP of 6, whatever, that's the number. And so anybody that's on CPAP is automatically on higher pressure than anybody maxed out on high flow. So even if we're at a PEEP of 5, just think of it as like this is like the next step up from high flow.
So notice anytime there's a leak, that's what you're going to hear. Okay? This includes when the baby decides that they're going to be rebellious and open that gaping hole in their face that they were born with that they eat and scream out of. Yeah, that's the first thing they'll do is they'll open up. We have chin straps for that to kind of help them along. We're also going to we're going to definitely use calming techniques as best as we can with this. Also, nothing by mouth. Okay, you've got that flow coming in, that flow generating pressure, you got a risk of aspiration. So back to why this piece is important. Because when you put this on the baby, small one goes first, and large there. You set that down over the child's nose. Now, when I do this, it'll create a seal and it'll stop doing what it's doing right now. But because this baby does not have fake lungs, that's how that works. Take this piece here. That piece there. And voila. That's all there is to it. I know there's a lot of steps. Okay. Now, how do I know that I've got good CPAP?
So
My numbers
not
look good.
alarming.
Not alarming.
Better work of breathing.
Better work of breathing, definitely. But it's the first thing I want to do whenever I have a good seal on the patient. I want to listen to them. CPAP does not go by the look. Okay, because this could be smushed up against the patient's cheek and giving me a CPAP number. You saw as I was there holding it, it's just saying, yeah, okay, that's 5 people. I'm happy with that. My tubing, I'll work with that. But I want to hear a good flow sound in the baby's chest. And that flow sound should improve as they recruit. So always listen to your patient. So far, so good. Big thing that you'll run into with respiratory therapists, especially, baby skin is tender. You know this as much as I do. But we like to do skin checks every 3 to 4 hours, and that includes the brow and the pressure points from where the mask holds right here on these sides, usually on the septum. Same with the prongs. We want to make sure that we're not able to drive a truck when we pig nose the babies, as well as the pressure points that are there, because skin can easily break down. Skin can easily be blistered, bruised, battered. We don't want that for any child. Okay? So, what happens if you hear this alarm? That was probably a bad example.
Something's unright.
You got a problem with either your oxygen or your air. Now, it will run, but the problem is, what you need to realize is which direction it's going. If it's an oxygen failure, your oxygen comes out and you have a baby who's on 40%. If you have an oxygen failure, your oxygen is going to go down to 21%. If it is an air failure, it's going to go to 100%. That is an analyzed value on your baby. Okay? So far, so good. What else am I missing, Joe, from our meeting?
I mean, my immediate question is like, is there anything that we can do to prevent the irritation, like from besides changing it out? Like, what if we see that this baby looks really skin breaking down?
Okay, we can duoderm or option B. Depending upon the size of the infant, is you can also go to and this is one of those situations where if we're at this point, I got to really consider it as maybe a trilogy and use it with the full face headgear where they look like they're wearing the Scuba Steve mask. So,
Yeah, I don't know if you've done any spend time in the NICU, but the breakdown is just a constant battle.
right. One of the things that I found that has helped me, and I know that it irritates a lot of NICU nurses, not just the children, is I usually alternate between prongs and mask every 3 hours. But I'm also a day shifter, and the baby's going to be awake more during the day, so it's easier for me to get away with that. But again, we're also doing skin breakdown checks every 3 hours, or should be, given that situation. And it hasn't failed me just, yet, knock on wood. But it was one of those tricks and habits that really got me to figure things out and say, okay, at least I'm looking. How can I alleviate this?
Jim, could you talk about like how fast we're going to see improvement, how long you get between weans, and then the upper limit?
Okay. So the hard part about this is, and this is what we discussed earlier, I can't give you hard and fast numbers to say that this is this, that's that. If I've got a baby chilling on a nasal CPAP of 6 and 28%, and they're happy as a lark, that's okay. They can stay and step down and be fine. But if I've got them on 6 and oh no, they look like garbage, we're up to 50% and they're retracting and let's go up to 7 and see how things are going to change. Just not going to be the case. We need to consider putting them in PICU. You're leaning towards that intubation line. So as a result, when it comes to what our upper limit would be, I'd say I would have a patient on a PEEP of no more than 7 personally. And that's just my preference, I think. I see Joe nodding in the corner there.
Your guys' expertise here.
Yeah. So it's just again, a personal opinion of mine. But again, if it's within reason to say that I've got a low O2 requirement and they're on 7 and they don't have obvious signs of respiratory distress, I'm willing to work a little bit with that. And it's tough because it is a guidelines world. If you have a subjective concern about the patient, though, we should be pushing to pick you. It's just the way of it. That's how I feel. So that's going to really be on assessment and, of what's going on. But again, always involving your RT, always involving your doctors, especially your attendings, to give you an idea of what that line would be. Again, definitely keep it going. Now, as far as how fast you will find a change, generally speaking, as the baby calms down, usually I see an improvement in about 10 to 15 minutes, which improvement as addressed as decreased retractions, less work of breathing, nasal flaring, head bobbing, relieved, lung sounds open. So that way you've got a nice, good flow sound in there. They rest better because they're not as tachypnic. When you're hungry for air, it's a scary thing. Kids get scared too. When they relax, when they calm, babies don't sleep if they do not feel safe. Struggling to breathe is not a safe feeling. Now, I see Adam over there. CO2 is too high, they won't breathe either. But, you've got a point, sir. However, when they're working to breathe, they don't feel safe. They will not rest. So you'll see that all calm down. Or let me rephrase that. You should see that all calm down. If not, and you're continuing on the same course again, you see going up by one, by one, by one. Well, it's time to change tactics. I'm just going to keep this quiet for now. So, all right. Any
Can you talk
questions?
about that little piece, like the restorative therapist? I just had a baby that was on this, like that piece that just dangles in the wind, like
This one here?
like the clear
Oh,
piece
my
here.
Okay, the clear
Like she
piece?
said, just like put a chucks under it, because like as a nurse, if I would have came and saw that, I'd have thought that it was unhooked somewhere.
Okay.
I didn't know that was a thing.
No, that's all right. So what this piece is, it's actually a way for the baby to breathe out. This is a single limb, so it's giving flow this direction. So it's got to have some way to vent. So all this is just an exhaust pipe.
What's the age limit for CPAP right now? 'Cause, I mean, nasal CPAP's not going to work on a school age kid.
No, it's not. Again, it's more of a measurement limit. To say that, if I could get, say, a 10-month-old that has a head, which would be a tiny head, has a head circumference under 42 centimeters,
Yeah.
then
And we're just not doing like face mask CPAP for like asthmatics or anything if we needed that.
generally speaking, though, and a good question. Asthmatics, I don't know that I would want to turn anybody bronchiolytic around up here because being that it's an obstructive process, I mean, yeah, it could buy you time,
Yeah.
but it could also increase your problem.
Yeah.
So, again, you can get everything in, can't get anything out. Oh, I'm sorry. Now I'm going to reset the alarm. But we are doing that.
Yeah.
We can buy you some time with a trilogy.
Yeah, I'm just trying to think of like, this is great for all the bronchiolytics who we can't get to the PICU in time. What can we escalate for like
Yeah,
for
an
more the
asthmatic.
early asthmatics or the pneumonia kids?
That'll have to be a discussion with the attendings and the ICU physicians.
Right.
I'm sure it's going to be a moving target, especially if we continue to stay in the crisis mode.
How about like the 2 or 3-year-olds? Like what's there?
Same deal.
Same
thing.
Right? Like the nasal CPAP, like Jen said, up to 42 centimeters head circumference. So like, if we can't do it, then we've got to talk about different strategies. And
Well, I know. Like, what point are you gonna need sedation with this as well, like prosthetics? Like, what if the child's agitated? You know what I mean?
that is being talked about. That is beyond the scope of this talk, but I'm sure we'll have another talk about prosthetics in the very near future. A good question.
Do you feel like babies usually do well with this, like agitation wise?
Agitation wise, it depends on the kid. And again,
Yeah.
for the most part, once you get them settled in,
Yeah.
they tend not to worry too much. I will say that I will lean towards this because when I start going towards Trilogy CPAP, when I start going towards the mass CPAP, they start losing their line of sight and then they panic worse. So at least with this here, they can see around it, and there's their field of vision, and they notice caregivers, they notice family.
Yeah.
It's more helpful to them in that respect. I will say you don't see a whole lot. Like the younger the baby, I would say the better they do, because again they adapt a lot faster. You know, I guess this is what we're doing. But the older the kid, the general tendency to move more towards Precedex is more common, I'll say. Not all the time, but more common. In my experience. I also do not harbor MD behind my name. So.
The two kids that have been here have been great. The one kid on Saturday threw a fit and we had prongs in his nose, and it took 3 or 4 people to make it happen. So don't be afraid to call when people buck these things off, because when somebody's bucking and you're trying to Velcro something and somebody else is trying to hold a head, it can get difficult. So I would encourage all of you guys to play with the straps while we're here, so you can see how they go on a plastic belt that's not going to fight you.
And I am going to cut the flow and the graphics. Everybody got an eyeful? That sort of thing. And that's really all you're reporting to. That's what I do when I make notes. This float here is nice. It's more for the respiratory therapist's edification to see how much flow it's taking to get a certain number of PEEP. If I have a flow of 11 to get a PEEP of 5, all that's telling me is I probably got a pretty big leak somewhere. Okay, that's for us to worry about. What you need to worry about as far as giving nursing report is what PEEP am I on and what FiO2. That's it. So he's on nasal CPAP of 5 and 21%. That's what you need to know. And if you want to, what kind of secretions, what their breath sounds are like, and what the plan moving forward is going to be to try it. Because 5 and 21 is pretty much limit. That's the lower limit. If the next move is we take them off, because we know that normal physiological PEEP for an adult is 3 to 5. What is it for a baby?
4 to 5?
3 to 5. Yep. It does not change no matter how big you are. So
If they do well on CPAP, would you put them to high flow, or would you just put them to like a normal nasal cannula if they're
depends on their oxygen requirement and their work of breathing.
Okay.
If I don't have to give them O2, great. Let's see what they do on room air.
Okay.
If I am on 5 and maybe 30%, let's see what they do on a quarter liter. And see if I can match it that way.
Okay.
Definitely, as much as they may or may not agree with you, nasal cannula more comfortable than having something strapped to your head.
For sure.
Do we still do you recommend still suctioning just as frequently?
Needed.
Okay.
As needed only.
And that's CPAP.
Especially
Setting
with RSV
room,
bronchiolitis,
coming?
RSV bronchiolitis, rhinoenterale. Always make sure that your suction is
CPAP
PR.
learning.
Okay.
So the thing that should
Come in
help
here.
Tressa is we use less sections.
Okay,
The
bye.
airways are going to be more open, so there's less chance of occlusion from all that suction. All that, not the suction, the secretions.
Well, everyone's in here.
And more of your problem, to Joe's point, is your nasopharynx. So if you can get away with suctioning with a nasal aspirator,
Yeah.
great. I do that. Deep suctioning in RSV bronchiolitis and in rhinoenterale could provide temporary relief, but not really proven. Also traumatic invasive, so could make your situation worse. But and that's the other thing I want to bring up too is cluster care. If it's time to go in for a respiratory therapist to make a check, make a look around, change the diaper, do whatever sticks that you need to do, change the bed, whatever, occupy their time. Because if we got to bother the baby once and calm the baby once, that's a lot better than, crap, I forgot that, and then you're doing the whole thing over again. Are they going to be rebellious? Yes. Again, the first thing I got to do is open their mouth. Without question, that's the first thing you're going to do is open their mouth. But in the meantime, again, we've got chin straps. We've got using soothing techniques. You can give them a bink, surprisingly enough. One of the things that they do is they usually cut the top to a binky, and they're to be pacified that way, and that's okay. So they're able to be pacified while they're on the CPAP network very well.